Hey everyone, welcome back to Analyze with Casey. Today we're doing something a little different. We're hitting pause to recap everything we've covered in this ARRT CQR prep series, and then we'll finish strong with our next procedure, the soft tissue neck. If you've been following along since the beginning, this is your chance to see how much ground you've already covered, and if you're just joining now, this will give you the roadmap of where to start and how to follow the journey. We began with the basics, what the ARRT CQR is, who actually needs to complete it, and who doesn't. That episode laid the foundation for why this playlist exists, to help you stay confident, qualified, and exam ready. Next, we started with one of the most common exams, the chest x-ray. We went over PA and lateral chest. We also broke down evaluation criteria like lung fields, costophrenic angles, and mediastinal structures. Then we shifted to patient care, covered communication, infection control, pharmacology basics, and medical emergencies. The ARRT sees patient care as just as important as technical skills, so this episode was critical. After that, we dove into radiation safety. Everything from ALARA to photoelectric versus Compton scatter, personal protection, and strategies to reduce dose to patient. Then our Abdomen Series. Our Abdomen Series tackled both routine exams and GI contrast studies. We started with AP supine, upright, and decubitus, then added contrast studies like esophagram, upper GI, small bowel follow-through, and barium enemas. Next up was fluoroscopy. Fluoroscopy got its own master episode where we broke down equipment design, image intensifiers, flat panels, automatic brightness control, and dose rates. We also tied in quality assurance testing and safety considerations. From there, we focused on image production, receptor exposure, spatial resolution, distortion, SNR, your sig-to-noise ratio, and how exposure factors affect image quality. We followed that up with a review of the radiographic equipment, generators, rectification system, and quality control checks that keep the unit working safely. But we weren't done with fluoro yet. So next we moved on to Fluoro Part 2. We looked at the genitourinary fluoroscopy procedures like the cystography, VCUG, IVU, retrograde urography, and the HSG. We also looked at myelography, arthrography, pediatric imaging, surgical C-arm. Next came the spine series. Cervical, thoracic, lumbar. We went through AP, lateral, obliques, swimmers, and flexion extension views. Because of how difficult the cervical spine can be, we dedicated an extra episode to cervical spine, covering trauma, cross-table laterals, obliques, and special odontoid views. After the spine, we moved into the skull and facial bones. We included Caldwell, Waters, SMV, plus trauma adaptations. We also included sinuses and nasal bones. Next, we shifted to the shoulder girdle. We covered AP internal and external rotation, brachy, Y-view, and outlet projections. We looked at the clavicle, AP and axial, and the AC joints with and without weights. Then we moved on to the sternum, SC joints, and ribs. We looked at above and below the diaphragm. Next came the humerus and elbow, laterals and obliques. After the humerus and elbow, we covered the hand and wrist. We looked at fingers, thumb, PA, obliques, laterals, and special wrist projections. And that brings us right up to where we are today. So far, we've covered chest, abdomen, spine, skull, upper extremity, thorax, and patient care essentials. The only big regions left are pelvis and the lower extremities. But before we head there, we have one more important study to knock out. And this one hits close to home. Just 2 weeks ago, my youngest, Phoenix, had another bout of croup. If you've ever heard it, you know how scary it is, the barking cough, the stridor, the struggling for air. We ended up calling the ambulance and riding to the hospital. Because he's had it so many times, we didn't need an x-ray to confirm it. We could hear it clinically. The sound alone told us what we were dealing with. But for many kids, especially if it's their first time with stridor, a soft tissue neck x-ray can confirm the diagnosis. That's why this study is such an important one to learn. Before we dive into positioning, let's quickly review the anatomy we're evaluating. The nasopharynx and oropharynx, the larynx, including the vocal cords, the epiglottis, the trachea, extending into the thoracic inlet. On the AP, we're looking mainly at the air-filled trachea and subglottic region. This is where we may see the steeple sign, the classic radiographic indicator of croup. On the lateral, our focus shifts to the epiglottis and airway patency, from the nasopharynx through the larynx and down the trachea. For the AP upper airway setup, keep the patient upright if possible. Supine is okay if necessary, but upright helps the airway stay open. Direct the central ray perpendicular to the mid-sagittal plane, about an inch above the jugular notch. Use a 40-inch SID, collimate from the external auditory meatus at the top through the thoracic inlet at the bottom. Take the exposure on a slow inspiration so the airway fills with air. On a good AP, the trachea and larynx are air-filled and midline. There's no rotation, and the sternoclavicular joints should appear symmetric. The mandible and occiput should not cover the airway. Soft tissue should be visible with a faint bone detail. In pediatrics with croup, you may see the steeple sign, that tapering, pointed narrowing of the subglottic airway that looks like a church steeple. That's the radiographic hallmark of croup. Now, for the lateral upper airway setup, the patient is upright, side against the IR. You want to center midway between the laryngeal prominence and the jugular notch. Use a 72-inch SID if available to reduce magnification. Expose on slow inspiration. Collimate from the nasopharynx at the top through the trachea at the thoracic inlet. On a good lateral, the nasopharynx or epiglottis, larynx, and trachea are visible. The airway should be dark and air-filled without shoulder overlap. The epiglottis is key. If it's swollen and thumb-shaped, that's a sign of epiglottitis, which is a medical emergency. The posterior vertebral bodies should align, confirming no rotation. Soft tissues should be visible against faint bony landmarks. Use a low KVP, about 60 to 70, to enhance soft tissue contrast. Keep mass low. Upright positioning is always best. A grid isn't usually necessary in pediatrics, but it may help with larger adults. If the airway is obscured by the mandible, extend the neck. If the trachea isn't midline on the AP, that means rotation. If the airway disappears, you're probably overexposed. And if everything looks blurry, slow the patient's breathing and repeat the exposure. All right, pop quiz before we wrap up. I want you to answer these in the comment section. What's the classic radiographic sign of croup on the AP soft tissue neck? Why do we expose on inspiration instead of expiration? And what's the key structure we check on the lateral to rule out epiglottitis? And that's the soft tissue neck study, a short but critical exam. For kids like Phoenix, sometimes the clinical diagnosis is enough. But for many, the X-ray provides the confirmation that guides treatment. We've now covered chest, abdomen, spine, skull, upper extremity, thorax, and the airway. Next up, the pelvis and lower extremities. We'll cover pelvis, hips, femur, knees, tib-fib, ankles, feet, toes, and calcaneus, with the same setup and evaluation breakdowns we've been using all along. If you found this helpful, don't forget to like, subscribe, and drop your quiz answers in the comments. Thanks for sticking with me. We're almost at the finish line of the ARRT CQR outline. I'll see you in the next one.